Great. Good morning. Sue Grinnell here with Public Health Institute, and I'm very excited this morning to have Alan Cheadle with us to share some of his work around this issue of dose. And I know that some of you are considering your portfolio of interventions, so I think it's just a nice way to kind of look at this, and he's going to dive into it. I've known Alan for, I don't know how long. How long have we known each other, Alan? A long time. And
seems like 20 years. You were a director in Calais, I think, at the time.
Yeah. I was a health department director, and I think we met then. And he's done this incredible amount of research on collaboratives and all kinds of things. And he is a senior research associate now with Kaiser. That was Group Health, but Group Health and Kaiser have merged. And so doing the same work, but under a different logo there. So he also just, I thought might be interesting to you, is he's doing some evaluation for the ACH sites in Washington State. So he has the perspective of what you all are working on. So, as you're beginning to ponder and consider your portfolio, I thought this might be helpful information to be in dialogue. So I really encourage you to ask a lot of questions. I mean, Alan's very open about all of that. And, he's provided a couple of examples from the logic model work that Suzanne and Kylie have shared with you all. So I'm going to just turn it over to Alan.
Great, thanks, Sue. And I'm not seeing, you mentioned Nicole, is she on? I'm not seeing her on the screen.
I don't have a video.
Okay, as long as you can hear. Can everybody see the slides? Is everybody seeing the title slide? It says healthy dose.
Yes.
Yep.
Okay, great. Okay, well, like Sue mentioned, we've been doing evaluations of coalitions for a long time, and it's challenging to do the work, it's challenging to evaluate the work, and one thing that comes up is what is the impact you're having? And often coalitions like ACHs have very ambitious objectives to have a community-wide impact on health and some health outcome measure, and very challenging to do. And this idea of dose grew out of an initiative we evaluated for Kaiser Permanente's National Community Benefit Program in obesity prevention called the Community Health Initiative. And so I'm going to go into that and how we kind of came up with the concept and give an overview of it and kind of move, not quickly, but through that, and then get to a couple of examples, like Sue mentioned, from your communities. So this is specifically, the concept is useful when you're interested in community-wide population-level impact, when you have a relatively well-defined outcome, and it doesn't need to be precise, but we'll get into that. And then also a portfolio of strategies that are often very heterogeneous. So there could be environmental strategies, there could be programmatic strategies. The idea is how to sort of talk about the combined impact of those things. So I think that fits where you're trying to get. You may not be close to that now, but I think ultimately that's kind of the goal. So let's see if I can move the slide forward. So are you seeing now a collage of photos?
Okay. Yep.
All right. So as I mentioned, this initiative started about 15 years ago. And the idea was to take communities, which eventually grew to be 60 communities around the country, but started out with a relative handful of communities, about 10 to 50,000 people. So they could be neighborhoods, they were some rural counties, a lot of different things. And they had a fairly ambitious goal to actually move population level obesity rates within their community by adopting healthy eating and active living strategies. So they were supposed to come up with things that would cause kind of the representative person in their community to be more physically active and eating better and overall sort of losing weight. And as you know, if you're involved in public health, population health at all, that's an incredibly ambitious kind of thing to try to do with limited resources and, you know, relatively large population. And what happened early on in the communities, it was a community-driven initiative. So they did have a lot of leeway in the things that they did. And early on, they tended to focus on very small programmatic things that reached small numbers of people, perhaps with good, strong interventions, but just small numbers of people, often uncoordinated, kind of all over the map. And that's not an unusual outcome when, you know, people come together and they have things that they want to do. But Kaiser was concerned that it wasn't enough collectively to really make an impact at the population level that they were looking for. And so we started talking about this idea of dose in the sense of how do you get a combined impact that's enough to be plausible for having that population level impact. And so the way we did that is kind of decompose the idea of how do you get that population impact into two components. So first you have to reach a lot of people, or at least a significant portion of the people in the community you're targeting. And that's sort of a requirement. If that number is too small, then you have no realistic chance of getting a representative person or a population level impact. And then there's the idea of strength, which is, if you're sort of familiar with the literature, the idea of an effect size. So what is the impact on each person that you touch? Is there likely to be an impact on them? And so the difference would be, you know, if you hand somebody a brochure, that's a very light touch. Do some education. Similarly speaking, it sounds like Amy in Riverside, you're doing diabetes prevention program. That's a much more intensive program, and it has demonstrated evidence of an effect size on, I think, transition to prediabetes or some diabetes risk factors. So it's those two things combined that are so challenging to get together. You know, you can have something that's very light touch that reaches a lot of people, like a media campaign or environmental strategy, or you can have something that's very focused, but it only reaches a small number of people. I'll just pause there for a second. Is there any, are you sort of comfortable so far in terms of the idea of population level change and then these two ideas of reach and strength? Any questions before we go any further?
You can also put things in the chat, you guys, if you're, you know, having any questions along the way, but I don't know if you have any, if it's making sense, you know, any questions?
Okay, yeah, and I can't see the chat, so Sue, you just relay if anybody has any stuff. So here's what this idea of dose can help you do. So first of all, as I mentioned, if you're not reaching enough people with something significant, you're unlikely to have a population level impact. That's sort of the first thing. The other thing is that you can use this idea to provoke conversations, which was probably the most useful thing in the community health initiative, was just to get people to think about essentially scale and impact. You know, are you reaching enough and strong enough intervention? Then in the evaluation end of things, what we did was we would quantify the impact. So we'd say, you know, what is the actual estimate of what percent change we expect to see in physical activity in this geography? And then try to see if, then we did population surveys in a number of communities to see if that lined up. So to see if they did enough high dose things to expect an impact that we'd actually see it. And then this last bullet, kind of, if you can't do surveys, which often you can't, this can give you a rough estimate of what impact you're likely to see. So here's a couple examples to sort of see how it's used, how the concept can be used. And these examples are all from healthy eating and active living, because that's what we've done so far. I think it's the concept is applicable to other areas, as we'll see. So if you can imagine starting a community collaborative like an ACH or like one of these collaboratives that were funded through the Community Health Initiative is starting out and saying, okay, how do we promote healthy eating? Well, how about we know that there are vending machines in the community centers in these neighborhoods, and maybe we can increase the number of healthy items in those vending machines. So you maybe you do some regulations, or you work with vendors and you get more healthy items in half of the slots in the vending machine. So then you say, well, that's, you know, sort of limited because people still have unhealthy choices. And so it's less strong of an intervention than if literally the healthy choice was the only choice. And so the vending ban would be something like, you can the machines no longer have the unhealthy, sweet, low nutrition value items. And then you can go from there. I guess this was the intent here was vending machines in schools. I'm now remembering. It's been a while since I did this, but suppose this was schools, so that you now you've taken care of the vending machines in the schools, but now there are other things that you can work on at a school level in the cafeteria, the foods that are offered in a cafeteria, or sometimes competitive foods offered in different stores or settings. And then going still further is to take the school and then maybe do things in corner stores around healthy eating. So the idea of dose is both making specific interventions stronger and then adding more things to kind of get to a larger impact. And I'll kind of, are there any questions about that? I'll assume that you'll just interrupt. Are you able to do that, or chat or something? Another example. Hello?
No, I just was laughing because it's like, yeah, just interrupt.
Yeah, we're a small group. So then and the corresponding things in active living in schools, so physical activity in schools is like, you may want to promote active transport to school, so you have a walk to school day once a year. And then maybe making that stronger is like a focus of sort of daily activities every day. And you combine that with complete streets, which is making more bike lanes and making it easier to walk to school, making it safer, and then bringing in other aspects like school physical activity. So the notion is you can increase dose by adding more interventions and strengthening interventions.
Well, and so Alan, just to kind of go, and those interventions are, you know, I think the catchy folks like to use the term mutually reinforcing, right? So they're not like random, but, you know, there's a strategy to that.
Yeah, and that's something we wrestled with a lot, was this idea of synergy and mutually reinforcing, because it's very hard to demonstrate. You know, we talk about evidence-based approaches, and you can look at individual interventions and say that's evidence-based, but the evidence around synergy, it's a very sensible thing. But so we kind of assume that you add these things up. They're additive, and we can go deeper into the weeds on that. But you're absolutely right. This forces you to think anyway about how they're linked together and how they might reinforce each other.
Mm-hmm.
So quickly, sort of what is reach? You know, how do we measure that? And it's a percentage, and it's a sort of penetration into the community of a given strategy. So it's the number of people exposed by the target population. And in the case of a program, it's easier because it's basically the number of participants divided by population size. So for a diabetes prevention program, you know, if there are 200 participants in a community of 10,000, then that's what the reach is. In environmental things, for example, built environment or park renovations or things like that, it's more difficult. And And we'll do things like, for a park, look at some radius around the park and look at the population who are sort of potential users as the reach for a given strategy. Strength is much harder. As I'm sure you know, there's just not a lot of evidence, quantitative evidence, on a lot of public health prevention strategies. And we really realized that when we started digging into the literature in certain areas. There are a lot of studies that they may find some kind of effect, but there's no number associated. Like if people, diabetes prevention programs example where there actually are numbers, and sometimes PE in schools has a similar thing where they actually said, well, kids will be 20% more active using this curriculum, things like that. But for a lot of strategies, we had to kind of rely on expert opinion, things like frequency, duration, intensity of the activity, to make estimates and put things in categories. So we had what we call minimal strength of 0.5%, so that's the lowest sort of amount we might expect something to improve as a result of the strategy, all the way up to like 10%, which is at a population level very significant. If you could actually increase physical activity or healthy diets by 10%, that would be quite an accomplishment. So the strength is the sort of weakest link in this whole thing, and that when we were trying to get actual percentage estimates, then we just a lot of times didn't have a lot of confidence in them. When to calculate it, you multiply the two percentages together. So for example, if you're reaching 50% of the people, say 50% of the kids in a school in an after-school program, and the impact on each kid is 10%, so that they're 10% more active overall in their day because they've been part of this after-school activity, physical activity program. So if you multiply 50% times 10%, you get 5%. And the meaning of that, or the way at least I think about it, is it's sort of spreading the effect over the entire population. So half the kids get an improvement of 10% and half get nothing. So 50% are essentially zeros because they're not going to the after-school program. So when you average across everybody, you get 5%. And if you do that to every strategy, then you have sort of a common way of adding them up because they've all been kind of normalized to be across the whole population. So if you can have a very intensive intervention like diabetes prevention program that may have a 20% effect size, but it's only reaching 1% of the people, then that's like a 2% or even is it 0.2% overall change when you spread it across the whole population. I'll pause there. This is where we lose almost everybody, in terms of this being a useful thing. What we found is that it's useful to talk conceptually about increasing reach, increasing strength, and that. But when we actually compute the numbers and add them up, then it's not easy to sort of think about these sort of things. But I'll pause there to see if anybody wants to ask questions.
Mm-hmm. Suzanne, I'm wondering if you have any thoughts or comments or reflections.
Well, I have been thinking about this equation, and I've been thinking about the difference from our work in SNAP-Ed that also uses a re-aim method to measure reach, and how we're just using a straight count of people. I just wonder why you went with the percent of people touched.
Yeah, and it's interesting because we borrowed heavily from re-aim. That was really a starting point for us. And their RE is reach and effectiveness. It's effect size. And they actually, in one paper, did something very similar to this. They're mainly focused on programmatic stuff. But if you don't do a percent, you kind of have to have a unit-free number to be able to add these things together. And so that's why we went with a percent. You can think about it in other ways, but if you have very heterogeneous interventions typically, at least in physical activity and nutrition you do. And so you have to have a way of sort of having a common denominator approach. I don't know if that makes sense.
It does. Thank you. Thank you for explaining that. I understand the rationale now. I was thinking about that. I was looking forward to speaking with you about it during the presentation. So. And
I'm happy if you want to follow up, looking at something you're doing or whatever we're talking about.
Okay, great. Thank you.
So what you can do is then think about different kinds of things. So this is, again, physical activity. So there's some programs like exercise classes that are low reach typically, but high strength. And they, if you go to an exercise class every day, you significantly increase minutes of physical activity during a week. High reach, low strength are things like this is a built environment intervention that's promoting walkability that may affect an entire neighborhood or community is influenced by that, but actual walking patterns are going to change relatively little. There may only be a handful of people that are now walking that weren't before. So the impact on each person is fairly low. And what you're looking for is high reach, high strength, where, and this is a school-based program, where we actually found that the schools were the most effective place to intervene, precisely because they can make all the kids do PE. They can make all the kids do better PE. And so they're reaching everybody. And because they have, and especially in elementary school, where there's more control over what kids eat and how active they are, can have a significant impact on each kid's minutes of physical activity in every day. We found it much harder to do things and have high strength, reach high strength things in the community setting, just more fragmented environment. So this is a little bit complicated, and I don't need to spend a lot of time on it. I'm sure Sue can send out the slides, or I can send them out. So this is the idea of sort of reach strength along the vertical axis, going from minimal at the bottom to low, medium, to high, and then reach similarly kind of going from minimal, low, medium, and high. And thinking about examples for a safe routes to school, and you may all be familiar with that, sort of active transportation to school, walking, biking to school, and how do you promote that? So in the very lower right-hand corner, minimal reach, minimal strength is something like maybe you have one day a month where everybody's encouraged to walk to school in one school. So you have a district with, say, 10 schools in the district, and they're only doing one thing one day in one school. So that's going to have very low impact and minimal reach and minimal strength. And then to increase the reach, so moving from that bottom right-hand corner to the left is sort of increasing the number of schools. And so that's sort of now from one school to half of schools. Increasing the strength, you can go to things like walk to school Fridays, so once a week, walking to school 2 days a week, or a daily walking school bus, which I don't know if you're familiar with that, but the parents volunteer to walk with the kids and they go and pick up kids at their houses and then all walk together as a group to school. And it's a big thing to organize, but if you can pull it off, you're going to have 10, 20 kids that add 20 minutes of activity or even more, 40 minutes of activity to their day. So there you can see if you have a daily walking school bus covering all bus routes in half the schools, that's a significant thing. An enormous challenge to actually pull that off, but if you could do it, you would have a good chunk of kids who live within walking distance, now getting up more minutes of activity. And you can do this with other kind of things. And this presentation was part of a dose game. So we do like a seminar. I mean, it's something to think about if further down the road, if you're you want to have your coalition sort of think about strategies, sort of apply a dose lens. We have a dose game where you can kind of do things like this. Try to imagine how you might either enhance the number of people reached or the strength.
Mm-hmm. Fun.
Fun. And then a couple more things, and then we can spend the rest of the time sort of going through a couple of examples to sort of think it through for the catchy. So this is a bit of a checklist for how you might think about increasing the reach of existing strategies. So can you expand programs to a wider audience? Can you do a better job of recruitment and outreach? Can, if you're doing a built environment change like the street work that was done in that picture that you just saw, can that be expanded and done elsewhere? And then something like a vending machine policy, can that be expanded to include other organizations? So this is kind of a checklist that you can use. Think about that. It can be tailored to your particular intervention. And then strength, can strategies increase frequency, intensity, duration? So that'd be an example.
Sorry to interrupt.
Yeah.
Can you just go back to that last slide really quickly, please?
Sure.
Thank you. I was just, sorry, just wanted to make note of the last point. Can the reach of policies be expanded? Okay. Thank you. That was all.
Okay. Yeah, I was having a little trouble hearing you, but I think.
She was just commenting on the reach of the policies be expanded. I don't know, Nicole, if you just wanted to clarify what it was, or if there was something, or Alan, if you want to give an example, maybe. Yeah,
and in nutrition could be like the vending machine policy that I mentioned, that you can have the city involved adopts a healthy vending machine policy, and then encourages the school district and other organizations to adopt it. Sometimes for schools, you can have policies around all sorts of things, physical activity, PE, activity.
Yeah, and maybe another example that's relevant to the group is you all have, leadership groups. So if you think about, one that I'd worked on, it's like when you're hosting meetings, there are oftentimes guidelines for that. And if you have guidelines, could something like that be adopted by all your members, right? So when you go to different meetings or they're hosting meetings, what types of food, are they serving pop or are they serving water, is a way that you can use, leverage, right, the policy capabilities of your ACH leadership. Is another example, I think, Alan, right? Like just using that group. Yeah, they're all representing organizations which have, a lot of power, right, to be able to go back into their own worlds to do that. So.
Yeah.
Nicole, was that helpful, Nicole, or
Yes, that was great. Thank you.
Okay.
So then the strength is frequency, intensity, duration. So the walking school bus example would be, more every day versus once a month. The choices that make a healthy choice, the only choice, we mentioned that in the vending machine idea, where it's sort of coercion, can you eliminate, and for elementary school kids, you can sort of say there's just not available, and then there are ways, and this, we'll get into a little of this in a couple of the examples, is can you strengthen the approach, like adopt a more best practice approach to something, whether it's health education or could be a clinical practice, or it could be another practice. And then sort of policies strengthened by making them more mandatory or adding incentives, things like that. Okay, so now I picked a couple examples, and I think in a lot of cases that your ACHs are in kind of early planning phases and have a sort of general area of interest, but maybe even narrowing on what specific outcomes you're focusing on. So this is kind of just more to have a conversation that's a little more grounded in what you're doing, and to shift a little bit outside of healthy eating, active living, so that you can see how the concept might be applied. So this is from Boyle Heights, and I don't think
no, Heather's not on. Yeah, which is too bad. Yeah.
So there's trauma-informed care, and it's actually something that's being done that Kaiser's very interested in, and their community benefit, and our ACHs in Washington State, several of them are looking at this as an option. So basically approaching, and it can especially apply to kids, sort of using that idea of focusing on trauma and as a sort of approach to counseling and therapy. And I think in Boyle Heights, they're thinking about enhancing access to trauma-informed care. And so in my mind, I'm thinking of, and Sue knows one of the ACHs in Washington State, which did this in a school. So they actually arranged to bring in a behavioral health counselor, paid for a behavioral health counselor trained in trauma-informed care to identify kids that were at risk and then counsel them. And it's an added service that they hope could impact things like, the kids' overall mental health, but then things like school outcomes and other things. So if it seemed like in Boyle Heights, they were trying to make this a community-wide strategy, and they wanted to increase the number of people receiving trauma-informed care. Mm-hmm. And I think the ultimate aim of that, and Suzanne, I think you had a logic model going out to more people getting access. But I think the ultimate goal would be community mental health status somehow. And this is a good example where you have kind of a high level concept, some ideas, everything from, depression to some overall well-being. There's lots of ways to think about community mental health status, but to sort of, I think one role of evaluation, one role of this dose methodology in particular is to get a focus more on what outcomes you're really concerned about. Mm-hmm. So, for example, it could be, depression. If you're going to do a population survey, what would you ask people? Would it be depression? Would it be stress? Would it be sense of belonging? Would it be, there are a lot of different sort of outcomes you could use. And an example here, a couple examples of population measures might be, there's a Poor Mental Health Day question in the BRFSS, the Behavioral Risk Factor Survey that CDC does, which is sort of a generic outcome. People sort of self-report how their mental health is. Or it could be something like community sense of belonging, which is a big issue now, mm-hmm. everything going on. So if you have an outcome like that, then the question is, how do you increase access? So that's where REACH comes in, is directly from the goal, increasing access to trauma-informed care, increasing the proportion of people either overall in the community or overall who have that need. So you can define your sort of quote community in different ways. Doesn't have to be all by geography, mm-hmm. but some sense of that. You want to increase access. And then the idea of strength here kind of goes to what we were talking about earlier about evidence-based and best practices. Is that there are best practices for trauma-informed care, and are those being applied everywhere where access is being increased? And also, are you kind of connecting people the right people to the right kind of services is another way of kind of increasing the impact, because if you get a better match with services.
Mm-hmm.
I'll stop there. This is kind of a sketch, and obviously it's not super well defined what their intervention will be, but this is kind of how you think about dose in this setting. And so I guess just thoughts, reactions, questions.
Let me just, thanks, Alan. So just a little bit more context since Heather isn't on. So when they applied for CACHI, they indicated that the chronic condition that they wanted to impact was cardiovascular disease. And much like you heard from Napa, for those of you that participated, is similar. They originally thought the issue was obesity, but then as they went deeper, it was food security, right? And then in Boyle Heights, what they found is it was trauma, and there's a lot of immigration issues. So they kind of pivoted, they did pivot. And, we did some work down there with them. And out of that, they decided the place that they could start is train all the staff that are there at the wellness clinic and their center in trauma informed, and those agencies that are there who maybe aren't placed, because they are coming from different places, that they would also get trained. So they've been doing a lot of training in the issue of trauma-informed care, and then plan to grow and expand from that. So that's just a little more context. And I think, Alan, when you and I have talked about this before, it's like starting with at least some outcome, right? Like, here's where it is that you're thinking you're trying to reach. And I think in some of the sites that may or may not be a challenge, like ultimately, but it's a place to start maybe, and then going backwards, right? Because, to be like, okay, well, what could be some areas of activity, right, and measurements that you could actually impact that. So anyway, that's just a little more context.
Yeah, and there's a choice you have to make, which is, well, sorry, did somebody else have a comment there?
I just wanted to ask a question, but it can wait after your comment.
Hello?
Yeah, Suzanne said to go ahead and she would ask her question after.
Oh, okay. So, now what was I going to say? I think it was about the measures. I think understanding the outcome, I think I already kind of mentioned it, that what you're saying, Sue, is that, oh no, I know what it was. You can, I mean, this is this idea of a community level impact. And we argued with Kaiser early on in the community health initiative and said, look, this is not realistic. Given the resources you're putting into these communities, you cannot expect to see anything like a survey-based measure change over 5 years. And so I think, there's a thought process or conversations around just kind of what you were saying, Sue. Let's train people. Let's get more people involved. Let's think about that. And even though you're not going to ever get to where you're actually measuring, tracking, and holding yourself accountable for mental health measures at a level of some community of thousands of people, but if you are committed to that, then this kind of framework can help you make progress on that. You do have to think about how are we going to measure it? It may be complicated to ask people, but at least it forces you to have that conversation. And I think that's in general what we found with dose, is that it's most useful for getting people to think about. We're investing a lot of money. Let's make sure we get the biggest impact we can have.
So I'd like to ask a follow-up question now. So from your comments, it seems like I'm just thinking, you know, a lot of people may get hung up on, we don't have population measures of mental health status for the community where we're working. I can't speak for Boyle Heights specifically, not knowing exactly what data they have, but I mean, the survey you mentioned, the BRFSS, you know, doesn't typically produce estimates that are going to be stable at such a small geographic level. So the outcome, are we trying to actually measure that, or is it just more like to guide us about where we're trying to go?
Yeah, that's a great question. And kind of what I was saying is that you can, I think it helps to say, what is it that we're hoping that trauma-informed care improves in people's lives? And so you can imagine, so you're sort of conceptually how, if you were going to ask questions, and if you did have the resources to do a survey, what would you want to ask people? I think you're right. It's a significant amount of resources to measure anything as complicated as mental health status, you know, at a community level. And you know, they do it at a state level. I mean, the BRFSS is designed to get state level estimates and maybe county level. And a lot of times that isn't relevant. So I think it is more about just getting concrete about the outcomes. And again, that can provoke conversations, community listening conversations around, okay, we're doing trauma-informed care. Is that getting to where we want to go, you know, in terms of the things that Sue mentioned, we're motivating that. I'm, you know, as an evaluator, obviously I have a bias, but I think when you try to think about measurement, even if it's something very complicated and hard to measure, it's still good to have the conversation.
Gets people.
Because you are trying to impact things. You are trying to make things better.
Well, and Alan, as I'm looking at this and just thinking about the one chart that you showed where there was different, like that mutually reinforcing, like obviously this is one activity, right, that's going to contribute to that. So that's where I think it gets complicated, you know, as they're trying to think about this portfolio of interventions and thinking about, you know, okay, so what are you going to do in the clinical? So it's kind of thinking about this, here's one maybe place, but then they're tasked with eventually thinking about clinical interventions and community, the linkage, you know, the policy and systems change. And just, I know Washington, because that's where you're evaluating, you know, that's not necessarily a requirement, but then where might, you know, those factors where, you know, like trauma-informed care could be in lots of places, like the notion of trauma-informed. And so how something like that might also impact the reach, right, or the measurement, you know, because you're it seems like doing it in many different settings, like we talked about earlier, is going to increase that, right? So I don't know if that made sense, but it's just, you know, relevant to this group in terms of what they're tasked with.
I think that's right, and I think in every setting you're going to have to do things a little bit differently. But there's sort of that second bullet in strength is sort of, okay, if you have it happening in a lot of different places, how are systems, how are people talking to each other? Are they, you know, taking similar approaches? And to the extent that you can track people, sometimes you can't measure at a population level, but for example, in the Washington ACH that I mentioned, they are measuring results at the level of individual kids in terms of school outcomes and things like that. So you can see whether you're getting the right people referred to the right places, and if they're having good outcomes. In a way, you could then project that up. You know, if we were to scale this, what would the community impact be? I think it helps you get a little more concrete. We say systems change a lot without being kind of vague about it. And I think if you have this kind of focus on outcomes and reach, and that you can be more concrete about what that really means.
Mm-hmm. Yeah. And I think
other thoughts or questions?
Yeah, any thoughts? I know Humboldt, you guys are thinking about this a lot. I think your next example is Napa, right? Like, and we've got Nicole on from Napa. So,
and it sounds like with my information may be a little out of date there. I just picked up from some earlier documents, like Sue mentioned, you were talking about fruit and vegetable consumption, healthy food access, but now it may be food insecurity. I don't know.
mm-hmm.
I mean, we're definitely looking at both of those things as being tied together.
Mm-hmm.
Yeah. So another case where, like with food insecurity, it really is about reach, and then so the number of people that have access to source of food, or it could be SNAP getting more people enrolled, or it could be more better coordinated food banks, and then the strength on the food access side could be both, like some food banks, food pantries have fresh produce, others don't, sort of increasing access to that, or maybe helping figure out ways to get people to prepare fresh produce so it fits with their sort of daily stress and things they're dealing with.
Mm-hmm.
But go ahead.
When you're doing this, do you generally, and I don't know if this is a good question to ask, but I'm just struck by the outcome measures, where they're coming from often, if it is BRFIS, or, sometimes there isn't necessarily great outcome. I mean, I know we talked about this outcome measures, but, because they are in Napa moving to food security. So I think, just thinking about what is the right outcome measure there, I think is, that's what you really want to ultimately impact, right? So anyway, I'm just thinking out loud about it.
Yeah, and we actually did some work. I don't know if you knew Scott Forsland up in Snohomish and his Sonoma Health Coalition. And one of the things, they had a food insecurity program that was doing backpack programs, I think, in schools, and so food insecurity was an outcome, and we were using or thinking about using. So there are a couple standard questions about food insecurity. In the last 12 months, did you not have enough money to buy food and things like that? And I mean, we were trying to sort of see how much each of these backpack programs could contribute to reducing that number. So it was a little bit different calculation. It was more sort of looking at this county as a whole, how many people are food insecure based on some county level survey data, and then what's the contribution of, say, 20 school backpack programs. And suppose that adds X amount of food to families' diet, and suppose you multiply that out, could you expect that food insecurity rate to go down?
Mm-hmm.
So it's kind of, it's a little bit different use of it. It's not quite multiplying those two percentages together. Mm-hmm. It's more about sort of almost directly counting. I think this might be, Suzanne, what you were getting at, why did you multiply percentages together? In some cases, you may have to modify the thing. So in this case, it's like, yes, no, are you food insecure? And then how many people can you improve enough so that they're now no?
Mm-hmm.
Does that make sense? I don't know.
Yes, thank you.
Well,
I think a lot of, when, I've been sort of, the School of Public Health for a long time, this idea of scale is a big problem for prevention programs, because if you don't achieve that, you're not going to move these big purpose-like measures.
Mm-hmm. Mm-hmm. Yeah, it just strikes me. I mean, the other thing is that in the sites, I mean, the way that this model was set up is it should be, and I think you were involved in these conversations, Alan, because of this work between 100 and 200,000 population, because they didn't feel like, in terms of some of these factors, you could make an impact. And of course, so you think of the overall population, but then the subpopulations of which they're dealing with. And so thinking about in those subpopulations, how many people there are there, and then where are the places that they go, and that, I'm thinking of Humboldt, right? They're doing work with homelessness, right? And, or the substance abuse. And so within that, like, what's your ROI? And where do you put your energy as a group, like as a system that's going to get you where you want to go, right? It's a lot to kind of take in and, to ponder. So it's good to kind of be having these conversations just to think about, them. So, I'm going to pick on, I see Jessica and Patty that are showing up on my screen. Any thoughts or reflections? I don't know if anybody else is on from Humboldt just regarding this for the work that you guys are doing. Or anybody else from Humboldt? Any thoughts on that?
Oh, sorry. Hey, Sue, this is Jessica. I had doubly muted myself, so can you hear me now?
I can, yeah.
Okay. So I think I probably don't have anything concrete to add. I mean, I think that's pretty interesting. We've been following it, or following the conversation this morning, just sort of watchful waiting. It certainly reflects that where we are in our process locally of trying to understand what set of activities go together for the highest impact. I don't know if Martin or Patty have any comments to add either.
Mm-hmm.
Hi, Sue, can you hear me?
Well, I know, and I talked to some of you a little while ago, I think, about what you're doing.
Yeah. Patty, I could hear you. Yeah, go ahead.
Oh, I just wanted to add, I think one of the challenges is, in calculating our reach, is in trying to understand how many people have substance use disorder in Humboldt County. That is our focus, and I think that, that's kind of traditionally been something difficult to measure, is, to really understand how many folks we're targeting, but understanding how many folks have substance use disorder. I don't know, just thought that might point that out.
Yeah, and that's a good example of one where if you're doing prevention or treatment, it's going to matter, whether you're focused on the whole population preventing, or if you're, treatment, and like you say, you have to identify, how many people and what different categories, and, it's going to be a lot harder.
Yeah, because I think for the like, I'm just thinking of the youth, BRFIS, right? Where for kids that are in school, you'll get that, and how many kids in theory, right, are in the school system. I think for adults, it's probably harder. So I think that point about prevention and treatment as well as maintenance, I know they've wrestled with that, like, if the house is burning down, so to speak, in the community, and people are wanting the treatment piece dealt with, but you need to stop the flow, right? Like, so just figuring out, what you do first and when, I think is a challenge also. Excuse me.
I just wanted to point out, and Sue, when you send out these slides, this toolkit that we put together is available online if you want to download that. It has more description and links, and you can always get in touch with me, and I'm happy to have a conversation if you're actually going to try to use this concept in either your discussions or planning or evaluation or what. Happy to do that.
Great. Any last questions, comments, any reflections from anybody? It'd be great to hear from you. Excuse me.
Did you say that you guys had published on this?
We have, and I think if you go to that link, you'll see some, but it's mainly sort of academic journal stuff. But I'm happy to send you that link, those articles if you want.
Yeah,
that
Ellen,
would be great.
Yeah, if you send those when I post this information, so I'll post the recording and the slides, then I'll put it with that, and then I'll just send a note out to you all to let you know when it's there.
Okay.
Great. Well, fascinating. It's really, I'm very grateful that you spent time with us today, and hopefully it's causing you all to think about these issues maybe on top of what you're already considering in this arena. So thank you.
Yeah, happy to do it.
Great.
Good luck.
Yeah.
Thank you so much.
Great.
Thank you.
Ellen, thank you so
Thanks.
much.
Thank you.
Thanks. Bye.